Today we'll discuss about mitral stenosis. In mitral stenosis, there is narrowing of the mitral orifice area. The area here is around 4 to 6 centimeters square. If it becomes less than 2 centimeters square, that leads to mitral stenosis. Because of some or the other reason, there is thickening of the mitral wall apparatus. And when mitral wall apparatus is said, it consists of a fibrous ring, annulus fibrous, over which are mounted the two mitral leaflets. And they are not just hanging between the left atrium and the left ventricle, but they are adequately supported by chorda tendineae. And these chorda tendineae are attached to the left ventricular wall by the papillary muscles. So the fibrous annulus, the mitral wall leaflets, chorda tendineae, papillary muscle, the left ventricular wall, and a part of posterior left atrium together form the mitral wall apparatus. And because of some reason, there is inflammation, thickening, fibrosis, scarring, the mitral wall apparatus is stenosed. It is thickened. Mostly it is the cuspal or caudal thickening. And because of this thickening, the mitral wall orifice area is reduced. So that will restrict the flow of the blood from the left atrium into the left ventricle during the ventricular diastole. So we'll define this mitral stenosis again. Mitral stenosis is a valvular heart disease characterized by the thickening of the mitral valve leaflets or the chorda tendineae, leading to reduction in the orifice of the mitral valve, thereby restricting the flow of the blood from the left atrium into left ventricle during the ventricular diastole. And since we have mentioned here that mitral stenosis develops when the orifice area becomes less than 2 centimeters square, we will also grade that. It is graded into mild, moderate, severe, critical. So 2 to 1.5 is mild, 1.5 to 1 moderate, 1 to 0.5 severe, and 0.5 is critical. Less than 0.5 is critical. Now once there is an inflammation and to develop mitral stenosis, what is the time duration it takes? Normally, the area reduces by 0.09 centimeters square per year, meaning in 1 year around 0.1 centimeter. So in 10 years, it will be around 1 centimeter. In 20 years, it will be around 2 centimeter. 2 centimeter area is reduced. So from the inflammation to develop mitral stenosis, it will take around 10 to 15 years. And if this mitral stenosis occurs in a child of less than 18 years, it is called as juvenile mitral stenosis. Now let's see about the causes of mitral stenosis. The commonest cause of the mitral stenosis is rheumatic heart disease. It is said that almost all the cases of mitral stenosis are because of the rheumatic heart disease. Other causes are very rare and they include mitral annular calcification, congenital mitral stenosis. Still rare causes of the mitral stenosis include Whipple's disease, mucopolysaccharidosis, carcinoid syndrome, amyloidosis, Fabry's disease. Whipple's disease, Fabry's disease, mucopolysaccharidosis, amyloidosis, carcinoid syndrome. These are the rare causes. And congenital mitral stenosis, mitral annular calcification are less rare. The commonest cause is rheumatic heart disease. And once there is a rheumatic heart disease, it causes rheumatic pancarditis, meaning pericarditis, myocarditis, and endocarditis. In the endocarditis, it will cause valvular heart disease and diseases of the chambers. And in valvular heart disease, mitral valve is most commonly involved. And in this mitral valve, in 25% of cases, mitral stenosis occurs, isolated mitral stenosis. In 10% of cases, mitral regurgitation occurs. Mitral stenosis plus mitral regurgitation occurs in around 40% of cases. So, mitral stenosis is more common than mitral regurgitation in a rheumatic heart disease. This is more common but takes 10 to 15 years. Regurgitation is less common but occurs earlier. And this mitral stenosis is, if occurs less than 18 years of age, it is called as juvenile mitral stenosis. Now we'll discuss why mitral stenosis occurs in a case of rheumatic heart disease. This is explained by a hypothesis called as Seltzer and Kohn hypothesis. According to Seltzer and Kohn hypothesis, once there is a rheumatic disease, there is acute inflammation of mitral valve. And once there is acute inflammation of the mitral wall, that will produce the aberrant blood flow or the altered blood flow across the mitral wall. This will cause the damage and again produce the inflammation of the mitral wall. When this continues for a chronic period of time, there will be thickening of the mitral wall leaflets. And because the mitral wall leaflets get thickened, the effective mitral orifice area is reduced, and that will lead to the mitral stenosis. Now, what type of stenosis occurs is, if this is the annulus fibrous, this is one cusp, this is other cusp. Now, mitral, this is one cusp, this is other cusp. Now, rheumatic heart disease is known to cause the vegetations. These vegetations occur along the free flap of the mitral wall leaflets, and these vegetations will later fuse. Right? They fuse and produce what is called as bicommissural fusion, and they progressively go on fusing, thereby reducing the effective area of the mitral wall. And after a period of time, it is reduced so much so that only in the center a small area is left. This is called as buttonhole stenosis or fish mouth stenosis. Right? So now we are seeing how does mitral stenosis develop in rheumatic heart disease. Now we will discuss what happens when mitral stenosis develops. Right. We'll start with ventricular diastole. When the ventricles are in diastolic phase, the pressure in the left ventricle becomes less than the pressure in the left atrium. As a result, the mitral wall opens and the blood will flow from the left atrium to left ventricle. Normally, this flow is laminar. There will not be any turbulence produced because the area is sufficient. Because of the mitral stenosis, the area is reduced. When the area is reduced, the ventricle is underfilled. But to maintain the antegrade flow of blood, the atrium will contract more. And when the atrium contracts more, the pressure in the atrium increases. There is a pressure overload in the atrium. That will maintain the flow of the blood, because when the atrium contracts, more blood will be ejected into the ventricle. That will maintain the cardiac output. But this occurs at the cost of the rise in the pressure in the atrium. Normally, during diastole, across the mitral wall, there will not be any pressure gradient. But here, since the atrial pressure is raised, there is a transmitral pressure gradient, diastolic transmitral pressure gradient, which is characteristic of the mitral wall stenosis. And once the pressure in the atrium rises, the pressure has nowhere to go but into the pulmonary veins. And once it enters into the pulmonary veins, this pressure over a period of time will lead to the pulmonary venous hypertension or pulmonary congestion. So pulmonary congestion or the pulmonary venous hypertension. Because there is a pulmonary venous hypertension that is transmitted back into the pulmonary capillaries, the capillary hydrostatic pressure increases, and when it becomes more than that of the interstitium, the fluid will transudate and enter into the interstitium. And when it enters into the interstitium, it will cause compression of the alveoli. And once there is a compression of the alveoli, there will be dyspnea. This is first point. Second, when the person assumes a recumbent position, from standing he assumes a recumbent position, the venous return increases. So blood from inferior vena cava increases, blood in the right atrium increases, right ventricle increases, that will flow through the pulmonary arteries, come through the pulmonary pulmonary veins, from the pulmonary vein into the left atrium, into the right ventricle, and the cardiac output should increase. This is normal. But here, when the person assumes prone position or recumbent position, the blood is faithfully conducted all along this pathway, but at this region, it cannot go into the ventricle. It cannot go into the ventricle effectively. So here the blood is coming from here, but the blood cannot go into the ventricle. As a result, the back pressure increases more. And when the pressure increases more, there is more accumulation of the fluid. And because of this more accumulation of the fluid, this is further compressed. The alveoli are further compressed, and so that will aggravate the dyspnea. So when the patient lies flat, he feels more dyspneic, and in the sleep, he may get up from the sleep after 2 hours and long for the breath. So that is paroxysmal nocturnal dyspnea. So dyspnea, orthopnea, and paroxysmal nocturnal dyspnea in a mitral stenosis indicate the development of the pulmonary venous hypertension. which has led to pulmonary edema. And if pulmonary edema has developed, it means that the pressure in the left atrium has increased up to 25 mmHg. Normally the pressure will be 2 to 12 mmHg. When these develop, it indicates that the pressure in the left atrium has developed up to the 25 mmHg. So these are the features of the pulmonary venous hypertension. Second, when this pulmonary venous hypertension occurs for a long period of time, then what happens? Whatever the fluid will be there in this interstitium, this fluid will slowly start entering into the alveoli. And once a fluid enters into the alveoli, that initiates the thickening of the alveoli. Obliterative changes in the alveolar wall. The basement membrane of the alveoli is thickened. So as a result, the diffusion of the oxygen is reduced. The diffusion of the oxygen is reduced. So the diffusion of oxygen is reduced because of the fluid in the alveoli, fluid in the interstitium, and the thickening of the basement membrane. As a result, the pulmonary veins carry less oxygenated blood, leading to the hypoxemia. And once there is a hypoxemia, this hypoxemic blood will enter into the left atrium, left ventricle, into the aorta, and into the carotid system. In the carotid arteries, the carotid chemoreceptors sense this hypoxemia. They think that less time is available for oxygenation, so less oxygenation is occurring, and they initiate reflex vasoconstriction. Reflex vasoconstriction of the pulmonary arteries. And because of this reflex vasoconstriction, there is development of pulmonary arterial hypertension. Now, this pulmonary arterial hypertension is developed because of reflex vasoconstriction. Reflex vasoconstriction has developed because of hypoxemia. That is because of the obliterative changes of the alveoli. And these obliterative changes have developed because of chronic pulmonary venous hypertension, which is because of the passive pressure transmission. Now, this passive pressure, the triad of the passive pressure transmission, obliterative changes of the alveolar wall, and the reflex vasoconstriction leading to the pulmonary arterial hypertension is called as Jordan's hypothesis. It's called as Jordan's hypothesis. And once there is a pulmonary arterial hypertension, the patients complain of chest pain. And when this pulmonary arterial hypertension occurs for a chronic period of time, that will exert pressure over the right ventricle. As a result, the right ventricle also undergoes hypertrophy. And this hypertrophied right ventricle over a period of time will undergo into the failure. So that leads to the right ventricular failure. And once there is a right ventricular failure, this right ventricle will exert pressure over the right atrium. So that will also lead to the enlargement of the right atrium. And the pressure will be transmitted back to the right atrium. From the right atrium, pressure is transmitted back to the superior vena cava and the inferior vena cava. So the features of superior vena cava and inferior vena cava pressure overload appear. So when superior vena cava pressure, back pressure in the superior vena cava increases, that will lead to the raised JVP, periorbital edema, facial puffiness, and engorged veins over neck and chest. But if it occurs because of the inferior vena cava pressure overload, that leads to the pedal edema, engorged veins over abdomen, and hepatomegaly. And once there is a hepatomegaly, the patients complain of pain in the right hypochondrium. Pain. So these are the features of the right ventricular failure. So here the right ventricle is enlarged, right atrium is enlarged, and also the left atrium is enlarged. Because of the pressure overload, the left atrium is enlarged. And once there is an enlargement of the left atrium, that will exert pressure over the esophagus, leading to the dysphagia, and also will exert pressure over the recurrent laryngeal nerve that produces hoarseness of the voice. Now, hoarseness of voice has developed because of the heart disease, which is called as cardiovagal syndrome or Ortner's syndrome. So, Ortner's syndrome or the cardiovagal syndrome is the hoarseness of the voice due to recurrent laryngeal nerve injury because of the left atrial enlargement. Right. And if this left atrial enlargement occurs, there over a period of time there will be fibrosis, and this fibrosis will replace the musculature of the left atrium, and because of that the muscle of the left atrium is destroyed, they are disrupted, and that will lead to the atrial fibrillations. And if there is a atrial fibrillations, there is stagnation because the atrium is not able to contract properly, pump up properly. There is stagnation of the blood, and once there is a stagnation, that will lead to the formation of the thrombus, and that may lead to the formation of the emboli, or it may also lead to the infective endocarditis. Here, the left ventricle, so except in mitral stenosis, except the left ventricle, all others are enlarged. And the problem with the left ventricle is it is underfilled, so the cardiac output will reduce. And once the cardiac output reduces, there will be fatigue. And because of atrial fibrillations, there will be palpitations. This is a symptom complex of the mitral stenosis. And it must be remembered that all the symptoms of mitral stenosis are raised in intensity or aggravated when there is tachycardia. So conditions like exercise, exertion, they will all lead to the increase in the intensity of the symptoms, because whenever there is tachycardia, the heart rate is increased. When heart rate is increased, the duration of the cardiac cycle is reduced, and the tachycardia or bradycardia affects the duration of the ventricular diastole rather than systole. So when the heart rate is raised, the ventricular diastole is reduced. So when ventricular diastole is reduced, there is a lesser time for the ventricle to get filled. It means atria has to work more and more in a less time. As a result, the pressure in the atria rises, becomes more than 25 mmHg, and all these symptoms will aggravate. Right? So we'll just have a rapid review of symptoms of mitral stenosis. Because of thickening of the mitral wall, the atria has to pump the blood more forcefully. That causes a rise in the atrial pressure, which is transmitted backwards through the pulmonary veins, leading to pulmonary venous hypertension or congestion. That leads to the increased hydrostatic pressure in the pulmonary capillaries. That causes transudation of the fluid, which compresses the alveoli, leading to the dyspnea. And this aggravates upon lying down. So orthopnea, PND, dyspnea, orthopnea, PND indicate pulmonary venous hypertension, which has gone for pulmonary edema. And if pulmonary edema develops, it means that the pressure in the left atrium is more than 25 mmHg. Next, over a period of time, this pulmonary venous hypertension will produce the transudate, will make the transudate to go into the alveolar wall. So there will be obliterative changes in the alveolar wall, like thickening of the basement membrane. And because of these obliterative changes, there is hypoxemia. Hypoxemia is sensitive by the chemoreceptors, which initiate reflex vasoconstriction that causes pulmonary arterial hypertension. The passive pressure transmission that has led to obliterative changes in the alveolar wall led to the reflex vasoconstriction. These three together leading to the pulmonary arterial hypertension is called as Jordan's hypothesis. Later, once there's a pulmonary arterial hypertension, that will exert pressure on the right ventricle. So right ventricular hypertrophy occurs. But over a chronic period of time, that will go into the failure. And when there's a right ventricular failure, there will be symptoms of the pressure overload in superior vena cava, inferior vena cava. If pressure overload in superior vena cava, rise JVP, periorbital edema, facial puffiness, engorged veins over the neck and chest. Because of inferior vena cava, there will be pedal edema, elevated engorged veins over the abdomen, hepatomegaly, and pain in the right hypochondria. And because the left ventricle is underfilled, cardiac output is reduced, it leads to the fatigue. Now, because of the pressure overload, atria becomes enlarged, and enlarged atria exerts pressure over the esophagus, leading to dysphagia, and pressure over the recurrent larynx leading to hoarseness of the voice, called as Ortner's syndrome or the cardiovagal syndrome. Then this enlarged atria initiates the fibrosis in the atrium. The muscle of fiber bundle is disoriented, disrupted, because that will initiate the atrial fibrillations, and patient complains of palpitations. And this atrial fibrillation will lead to the thrombus formation, thrombus into emboli formation, and there may be chances of infective endocarditis. So the complications of mitral stenosis are pulmonary arterial hypertension, right ventricular failure, atrial fibrillation, thrombus formation, infective endocarditis, and embolization. So now we have discussed about the symptom complex of mitral stenosis. Then we will discuss what are the signs. So here there's a lot of back pressure. There's a malar flush, this pinkish discoloration of the cheeks, that is called as malar flush. And the pulse will be usually normal, but if it is in a atrial fibrillation, the pulse will become irregular. Now we'll speak of cardiovascular system. Upon inspection, what happens to the apical impulse? Right? Apical impulse will be shifted outward because the right ventricle is hypertrophied. Whenever there is a hypertrophy of the right ventricle, the apical impulse will be shifted outward. But if there is a hypertrophy of the left ventricle, it will be shifted both downward and outward. Right? So downward and outward in case of a left ventricular hypertrophy, outward in case of a right ventricular hypertrophy. This is because of the orientation of the base of the heart in this direction. Right? So apical impulse is shifted outward and the apical impulse is tapping. Second, upon palpation, because of pulmonary arterial hypertension, P2 becomes, that is second heart sound, pulmonary component of second heart sound becomes so loud that it becomes palpable. So loud and palpable P2. Now we will discuss about the heart sounds. What happens to heart sounds in a case of mitral stenosis? And for this we will draw ventricular systole and diastole. This is ventricular systole, ventricular diastole, then ventricular systole. First is S1. S1 occurs due to the closure of these valves. So when the ventricles start contracting, the pressure in the ventricle becomes more than the pressure in the atrium. To prevent the backflow of the blood, the valves close, leading to the S1. Here, during diastole, when the blood is not going from the atrium into the ventricle, the left atrium has applied a lot of pressure over the mitral valve. Right? So because of this lot of pressure, they are more widely separated. So when they clap, when they close, they become loud. So first thing is loud S1. The intensity of the S1 is increased. Loud S1. Second heart sound has two components, aortic component and pulmonary component. Because of the development of the pulmonary hypertension, there is loud P2. Intensity of P2 is increased. And after ventricular systole, what happens? There is ventricular diastole. This is divided into early diastole, mid diastole, later diastole, and ventricular systole. After this, what happens is here, after the second heart sound, when the ventricles relax, during diastole, when the ventricles relax, the pressure in the ventricle becomes less than the pressure in the atrium. So the blood will rush down upon opening of the valve. But here so much of pressure will be there in the atrium that it causes forceful opening of the valve. And this valve opens with a snap, which is called as opening snap. So opening snap. So when valves open, they should open silently. There should not be any sound. But here the pressure is so much in the left atrium that when valve opens, it opens forcefully with a sound which is called as opening snap. And this opening snap occurs 40 to 120 millisecond after the A2. Then when the ventricles is relaxing, the blood flow is not normal. That is turbulent. And this turbulence will produce vibrations. These vibrations travel at the speed of the sound. So they produce what is called as murmur. And this can travel in left ventricle or into the left atrium because sound is a mechanical wave. But other diastole, there's more blood in the left ventricle, more molecules in the left ventricle. So this sound which is produced, the murmur which is produced, will travel along the left ventricle and will reach the chest, where the left ventricle is close to the chest, and that is at the apex. So that produces mid-diastolic murmur. So mid-diastolic murmur is a soft murmur and is a low-pitched murmur. Since it is a low-pitched murmur, it is best heard with the bell of the stethoscope. And the nature is rumbling. Best heard at the apex with patient in the left lateral position. Because when patient assumes a left lateral position, the apex becomes close to the chest wall. So it is better heard. So mid-diastolic murmur in case of mitral stenosis is a soft, low-pitched rumbling murmur occurring in the mid of the diastole, best heard at the apex, and patient being in left lateral position. Right. Then sometimes when the atrium contracts, the last 20% of the blood is ejected into the ventricle. But here, again, when the atrium contracts, the turbulence increases because atrium is contracting against a stenosed wall. So the murmur which is reduced by the end of the mid-diastole will again get accentuated because of atrial contraction, which is called as pre-systolic accentuation. Systolic accentuation. So this is the mid-diastolic murmur. But sometimes in the acute stages, this mid-diastolic murmur is called as Kerry-Coombs murmur. The mid-diastolic murmur, classic mid-diastolic murmur, is called in the chronic mitral valvitis leading to mitral stenosis. But earlier, when the first attack of rheumatic fever occurs and it causes inflammation of the mitral wall, that will produce a turbulence according to Selzer and Kohn hypothesis. That turbulence then produces a mid-diastolic murmur, which is called as Kerry-Coombs murmur. But here in chronic stenosis, it is the classical mid-diastolic murmur of the mitral stenosis. Also, sometimes we now understood that because of mitral stenosis, there is pulmonary hypertension. So because of this pulmonary hypertension, there may be incompetence of this pulmonary wall. So during the diastole, when the ventricles relax, when the pressure in the ventricle becomes less than the pressure in the pulmonary artery, normally the wall should close so as to prevent the regurgitation. Here, because the wall does not close, there is a regurgitation. Right, and this regurgitation of the blood will produce turbulence and a murmur in the early diastole. Right, so this is a high-pitched blowing murmur, which is seen in the P2 region, that is second intercostal space parasternal region, which is called as Graham-Steele murmur. So Graham-Steele murmur is a high-pitched blowing murmur, best heard at the P2 area, which is because of pulmonary hypertension secondary to the mitral stenosis. Right. So these are the heart sounds. We'll have a quick review. First, S1 is loud because the walls are more excruciated, more separated. P2 is loud because of the pulmonary hypertension. There is an opening snap which occurs because of the forceful opening of the mitral wall due to increased left atrial pressure, and this occurs 40 to 120 milliseconds after A2. Next, there is a mid-diastolic murmur, which is soft, low-pitched rumbling murmur, best heard at the apex with patient being in left lateral position. And this occurs because of the turbulent flow of the blood. And when the atrium contracts, this will get accentuated, called as pre-systolic accentuation. And this murmur, if heard in the earlier stages of the rheumatic fever, it is called as Kerry-Coombs murmur. And when there is a development of the pulmonary arterial hypertension that produces the regurgitation of the blood, in early diastole, there will be murmur heard, which is a regurgitated murmur. So it will be high-pitched blowing murmur called as Graham-Steele murmur, heard at the second intercostal space left parasternal area or the pulmonary area. So this is about the heart sounds in the mitral stenosis. Now we will discuss about investigations in a case of mitral stenosis. In any valvular heart disease, the investigations are chest X-ray, ECG, and echocardiography. What happens in chest X-ray? What happens in ECG and in echo? Echo is the choice of investigation because it will show the mitral wall, stasis of the mitral wall, the thickening of the mitral wall, stenosis of mitral wall, and also flow of the blood. Right. So this is the investigation of choice. In the ECG, in a lead 2, there will be P mitral, or there will be bifid P wave, notched P wave, which is called as P mitral, and other changes of the pulmonary arterial hypertension. Right. Then what happens in X-ray? So when X-ray is taken in a posterior anterior view, it shows evidence of 3 things. First is left atrial enlargement. When there is a left atrial enlargement, this left atrium, this is a left atrium, right? So when there is a left atrial enlargement, first the border will straighten. This is normal atrium. There is enlargement, the straightening of the border occurs, and there will be double density shadow. And this left atrium will push the left bronchus upwards, leading to the splaying of the carina. This interbronchial angle is increased. So in X-ray, if there is a left atrial enlargement, it is evidenced by three things. First, straightening of the border of the left atrium, double density shadow, and splaying of the carina. Second, pulmonary arterial hypertension. Right? If there is a pulmonary arterial hypertension, it is evidenced by increase in the diameter more than 17 mm. This pulmonary artery, whatever is there, the shadow which appearing here, this pulmonary artery diameter will become more than 17 mm, and in females it will become more than 16 mm. Third, pulmonary venous hypertension. It is possible to grade also, grade 1, grade 2, grade 3. So when there is a pulmonary hypertension, in this X-ray, if there are prominent upper lobe veins, it is said to be grade 1. And if there are markings in the base, apex and center, they are called as Kelly B, A and C lines, then it is grade 2. And in grade 3, there will be bat wing appearance of the pulmonary edema. Right? So these are the three features that can be seen in X-ray, and also enlargements of the heart. Then treatment. So most of the causes of this mitral stenosis is a rheumatic heart disease. So the first step in the treatment should be penicillin prophylaxis. Second, treat symptomatically. There is a pulmonary venous hypertension, treated by diuretics. The diuretics commonly given here are furosemide 20 to 40 mg per day plus spironolactone, which is around 25 to 50 mg per day. After this, what is it? Tachycardia. So tachycardia will increase the symptoms. So reduce this tachycardia by giving beta blockers. Now what is there? Atrial fibrillation. So reduce the atrial fibrillation by giving digoxin. And there's a decreased cardiac output. Increase the cardiac output by giving digoxin. Then thrombus formation. To prevent the thrombus formation, give anticoagulation. So these are the things: penicillin prophylaxis, diuretics, beta blockers, digoxin, and anticoagulation. In some patients who do not respond to this, where there is a severe mitral valve stenosis, balloon mitral valvotomy or mitral valve replacement is done. This is about the mitral stenosis.